Thank you, Carrie, and good afternoon, everyone. Thank you for joining us today. I'm going to follow on Dr. Keller's presentation, who gave us a really good baseline on how to understand the importance of alternative payment models. And I'm going to tell you a little bit of the mechanics and how the Center for Improving Value using the Colorado All Payers Claims Database have been working to produce a report on primary care spending and the percentage of spending that is done in alternative payment models as Dr. Keller described. And this started in 2019 as established by the House Bill 19 1233, and you will learn much more about it later. CIVHC started collecting APM files, which are in addition of claims files, to produce a report that will inform the spending that is done in Colorado in primary care out of total medical spending, and what share of that spending is due to alternative payment models, which is the intention of this bill, not only to increase utilization of primary care, but also to do this through the investment on alternative payment models. Could you tell me, go to the next slide, Carrie, please. And I'm going to tell you a little bit of the history of the alternative payment models. As I said, the collection of APM data started in 2019. And at the beginning, Colorado adopted the model used by Oregon Health Authority to produce the first primary care spending report and first APM spending figures. But in 2020, with the establishment in the Division of Insurance of the Primary Care Payment Reform Collaborative, the collaborative implemented a specific definition of primary care for the state of Colorado, and they also implemented the HCP land categorization for APM collection that was described also by Dr. Keller. And that was important because then that meant that we worked together with the collaborative and the DOI to create an operationalization of the primary care definition using the claims, and also to request the submission of non-claims data. We also discovered as a result of the first report that we needed to make some technical modifications to the APM data collection, and that was mainly to use Colorado residents instead of the place of the legal contract of the health plans, and also to add the line of business detail. The way we collected data before, we couldn't provide that detail. But in 2020, which was the most recent data collection, many changes, very important changes were adopted, and the most important change was to identify in the files what payments are done prospectively, because that's important for practices and for primary care transformation particularly. But we also included a qualitative supplement to the APM files quantitative submission. What this qualitative supplement does is that health plans described all the contracts that go into the final APM numbers, and they describe each of the contracts along a series of characteristics. For example, they describe if the contract, first they describe if the contract is classified as a 2A, 2B, 2C, where it's classified according to the HCP land framework. And then they describe if it is population-based, if it is prospective, if it has upside risk or downside risk, all the characteristics that are included to classify alternative payment models within the HCP land framework. This is very important information because that allows us to check with health plans that the operationalization of the data they were submitting corresponded with the intention of the category in the HCP land framework. So that was very important and helped us improve the data collection, the validation, and the engagement with carriers beyond only the data team of the health plans, but also the policy team of the data health plans. And that drives also the attestation. I don't want to miss to say one thing, that this work that I am talking about now is just me, but represents a very large team in CIVHC that goes from the data collection quality team and then the reporting team also. Could you go to the next one, Kerry, please? Just to tell you a little more about the process of data collection, CIVHC receives APM test files from each of the payers that submit APM information in July. And then CIVHC validates that data against the HCP line framework and the contract, talks with the carriers, has many conversations, and then we receive the fixed or a revised file later in the year in September. This file is again, it might need other adjustments. That is done, and then we receive a final attestation at the end of, before the report is due in November. One thing that is important to mention is that not all health plans in Colorado pay through using alternative payment models. So the first step is that those payers who do not pay using non-fee-for-service ways, they request a waiver to submit data to the Colorado APCD. That waiver is granted, and then it is only 13 payers, for example, in 2021, who submit APM data to CIVHC for this report. Could you go to the next one, please, Kerry? Okay. What we have learned since we started collecting data, one of the first things, and of course, Tara and Dr. Keller are very familiar with this. One of the first decisions that had to be done about what constitutes total medical spending is that if we were going to include pharmacy, dental, or vision services, as it is right now, total medical spending does not include pharmacy, dental, or vision services, and not including these is pretty much the way other states have done it, but there is always like the question: is this the way we want to stay, or is there an opportunity to modify the denominator and include all the other expenses in healthcare? One thing that we have learned is the value of continuous engagement with health plans, and by continuous engagement, meaning not only with the data teams, but also with the policy team, making sure that bridge between the conceptual part of how the APMs are designed translates to the data that we are receiving for these reports. And also, of course, the implication of primary care definition. As you know, many other states have been adopting similar initiatives of increasing spending on primary care, and each state defines primary care different. And just to add to that, each payer, each health plan defines primary care providers different for the plan. So what Plan A in Colorado identifies as primary care provider might not coincide with which Plan B identifies as primary care provider. Of course, we as the recipients of the data guide the submitters with a specific primary care definition, but we need to make sure that definition is followed, and that is, as you can imagine, is not straightforward, particularly in the non-fee-for-service plan part of the equation. The other thing that we have continued to work, and we still have to continue working on, is to make sure that the way Medicaid is paying for primary care and alternative payment models is represented the best way in the data. And as you know, the Colorado APCD receives payments from all the health plans, and Medicaid, as the state agency, pays directly to some provider, but also we received information from the health plans who are contracted to manage the accountable care collaboratives. So we need to make sure that all these pieces are represented properly, and we continue working very closely with Medicaid to achieve that. I think we made great progress from 2020 to 2019, but we know we have still more to do. And I would like to mention also another piece of challenge in the collection of APMs is how we are categorizing the HCP LAN. I think Dr. Keller said it well, the devil is always in the details. And many states have adopted the HCP land framework as the categorization, as the standard categorization for APMs, but we don't know to what extent we might be operationalizing those categories differently when we collect and report the data. So there is still more work to be done. And the other piece that is very important to mention is what is going to be the level of aggregation for the APM data collection. So far in Colorado, we are collecting data at the billing provider level. But as we progress and we adopt APMs, we would like to see if those APMs are making a difference in the population health, care, and access. And for that, we're going to need more information about who is being covered under these APMs and who's not. So we might need to add other layers of or other data points to the data collection. Next one, please. And this is just a very, very broad overview of the alternative payment model spending in Colorado. I invite you to go and check the report that is available in the website. This is the percentage of alternative payment spending out of total medical spending from 2018 to 2020. In these graphics that are broken by Medicaid, Medicare Advantage, and commercial, what you can see is that we are also including integrated systems in the state of Colorado, and we are including all types of alternative payment models, not only value-based payments, as Dr. Keller made that difference. And if this is any non-fee-for-service payment is included here, and we are also including the share of integrated systems who take care of a very large segment of the population in the state of Colorado. You can see that the spending seems to have decreased a little bit over 2018 and 2020. I have to say the 3 years we're collecting in one data submission in 2021. So they are all exactly comparable data with the same parameters and same data submission. Next one, please. I forgot one point from the other one. Could you go back, please, Carrie? So this is for each of the payer types, but if we overall across all the payers from 2018 to 2020, if we look at the percentage of APM spending, we saw that we had 38% in 2018, and it came down to 33% in 2020, if we include integrated systems and APMs. And now the next one. And in this one, it is exactly the same, but in this case, we are not included the integrated systems, and we are only including the value-based APMs. The value-based, those who have quality, those who have a measure of quality. So in a way, the first one would be the more like the less strict measure of APM, and in this case, is the more strict measure of APM, or ideal measure of APM. And as you can see, also, there is a decrease, particularly among the commercial payers, not so much in the other payer types. And in this case, the APM percentage spending went from 27% to 21% in 2020, from 2018 to 2020. Next one, please. This is just another view for only commercial payers in 2020, and commercial payers overall spend only 11% of their total medical spending in alternative payment models or non-fee-for-service. Next one, please. And this is a little bit more detail on what type of alternative payment models they used. And this is also for all the payers in 2020. And you can see that still the most predominant type of payment is pay for performance, which is, as Dr. Keller explained, what we would like, ideally, we want to move to force instead of two, which is still like in transition to adopting full alternative payment models. But it is still pay for performance, the most predominant type of payment if we do not include the integrated care systems in Colorado. And just a last word, because I think this is the last oh, well, this is just the affordability dashboard, which you can go and see. These were just a few data points that you can find in the dashboard. But I just wanted to mention that you see like the decrease of APM spending in 2020, but we know very well that 2020 was a year like no other. So we collected data from the health plans. We asked if in which way COVID had affected their primary care spending and their APM spending. And even when qualitatively, most of the health payers said that primary care, of course, decreased for a time, but then came back. If you look at the data, you see that for most payer types, with exception of Medicaid, the primary care spending actually decreased in 2020. And in APMs is about the same. Payers said that they didn't perceive a big change, but the truth is that the APM spending decreased also for pretty much across the board, with exception probably of Medicaid also. And one thing that is that we know and is that we will need to do many other analyses to just make sure what is exactly different and what happened with the spending during 2020 to make sure that change, because they didn't change the APM spending, but something else changed because we are seeing the decrease overall in 2020. And that's all I have. I invite you just to see the report whenever you have a chance and come back with questions. Thank you.